Good evening, everyone. I thank TCT for giving this opportunity. Today, we are going to discuss about sepsis vein graft intervention under IVA's guidance. We are discussing this case from Care Hospital, Hyderabad. When coming to clinical history of this patient, there is a 74-year-old male, non-diabetic and hypertensive on regular medications, with past history of an old inferior MI and done PTCS 10 to RCA. Later, he underwent a cabbage in 2011. Grafts were Lima to LAD, SVG to OM, and an RCA. After this, he was stable over the last 10 years. Presently, was admitted with a chest pain, diagnosed to an ACS and STEMI. Echo was done, which was showing an inferior wall akinesia with mild to moderate MR. LVF was around 50%. Blood investigations were done. Other parameters were normal. We have found a creatinine of 1.8 milligram per deciliter, and he was stabilized and taken for an angiogram. This was his angiogram fix, where we can see an LMCA was ostial occlusion. Lima to LAD, good graft and patent with good distal flow in LAD. This was an RCA angiogram, where you can see in a proximal there was stent noted in an RCA with good distal TME flow. The early branch in PLV, you can able to see distal TME1 flow with mild ISR. When coming to an graft, SVG to OM, this looks like a culprit lesion where you can able to see this proximal part, severe critical stenosis, and the distal at the anastomotic side, severe critical 95% stenosis. This is the same SVG to OM graft where you can able to see clearly the proximal and the distal critical stenosis and the good distal flow in an OM graft. These variable SVG to OM was critical stenosis. Then plan was to use an SVG graft intervention in view of need. When coming to the background of an SVG, ischemic symptoms occur in around 5% of patients per year following CABG. Recurrence of symptoms can be attributed to progression of the native vessels or the bypass conduits. At 10 years post of approximately half of all SVG conduits are occluded and only half of the remaining SVG grafts are free of significant disease. In around it accounts around 5 to 10% of PCI case volume in any centers. If you see an SVG pathology, these are not like native arteries. They can often stenose within 10 years and 50% will occlude by 10 years. They often acts like conduits and they do not have vascular tone like arteries. Morphologically, SVG lesions tend to be diffuse, concentric, and fibrable with poorly developed or absent fibrous cap. If you see this pathophysiology of venous graft disease, it can be an early disease or intermediate. In our case, it was a late. It occurred beyond 1 year, most of it due to atherosclerosis. The significance in will be the plaques here will be less fibrocollagenous and less calcified. So they are more softer and pliable and of a larger size and frequently associated with thrombus. This is the why most it will cause an embolization. Most of it will due to mechanical plaque disruption caused by our balloons and stents, which will able to cause distal embolization, causing microvascular obstruction via plugging when secondary spasm and the platelet aggregation. So the interventions in degenerated saphenous vein grafts will be associated with complications like distal embolization, no reflow, abduct closure, and perforation. The lesions that are most of it bulky and associated with thrombus. And what are the things I need to be kept into account when doing an SVG PCI? Whether you are going for a direct stenting, what are the thrombus management, embolic protection devices, vasodilators, and the stent sizing issues. So we have taken a plan was SVG graft intervention. We have taken an AR2 guide for good support. C and blue wire was used. IVAS imaging guided was taken with often renal dysfunction. Initially, there was difficulty in crossing this wire with because of distal lesion. C and blue wire was caused. And we were pre-dilated with 2 into 10 mm. The lesion was inadequately pre-dilated. If you see, there was a gross discrepancy between the distal and the proximal vessel. So here, because there was no distal landing zone, so embolic protection devices were not kept, which is usually is in a class 1 indication for preserving antegrade flow and preventing the distal embolization. So the distal anastomotic site, we have kept in a 2.5 into 28 mm drug eluting stent. Initially, there was mild under expansion here, dilated with 3 into 10 because the proximal vessel is very weak when compared to distal 3 into 10 post dilatation was done. For the proximal and SVG-OM lesion, we have deployed a 4 into 22 drug-eluting stent. After this, we are able to see as an haziness in the distal edge of this proximal stent, which was not shown previously. So IVUS was done. This was an IVUS run from SVG graft. Distally, there was no much plaque burden, mild disease. Distal landing zone was good. It was not landed in any disease. Still coming distally. Stent is adequately expanded and opposed. Stent is adequately expanded. And after this, in SVG graft, there was no much lesion. Still coming proximally. The graft looks okay. Concentrate at this area. Coming still proximally, where you can able to see at the 7 to 10 o'clock, there is a calcified plaque and the lesion looks like still coming proximally. Where you can able to see a haziness suggestive of a thrombus from 6 to 10 o'clock position, just after the distal edge of this proximal stent, and the stent looks a mild underexpanded and opposed. Though IVUS guidance has helped us to see that a calcification which should not be usually there in an SVG lesions, and there was a large thrombus, the diameter of the vessel was helped us to take a stent and the post dilatation. This was this angiogram picture after deploying the stent, where you can see an haziness of the distal edge of the proximal stent. So we have done a 4 into 30 onyx stent was deployed. Because of an IVUS help, we have done a post dilatation with 4.5 into 8 and 5 into 8, and a good distal TME3 flow was obtained. This was the before intervention, and this was after with a good distal TME3 flow. IVUS has helped us to post dilate even to take in a 5 into 8 NC balloon for an adequately post dilating. The take-home message is distal embolic protection is class 1 indication. It's an effective. Pharmacological vasodilation should be used slow flow. In our case, the distal stent need to be expanded adequately. There was no landing zone, so embolic protection device was not used. IVUS has helped us to know the thrombus and calcification. Patient should be monitored long-term, and long-term DABT is recommended. Thank you.
So comments, please. Dr. Jabir, Dr. Vijay, Dr. Pramod.
I think the moment, good to see you, everybody.
Yes, I think it is a well-done case and demonstrates that in ACS with the vein grafts, a thrombotic burden is possible. And sometimes what we can do is keep the patient on heparin infusions because it is not emergency case here. It is called marinating the vein graft, and subsequently the burden will be less. Because as you know, the 2B3 inhibitors are not useful in the vein graft interventions. And definitely they need to be commended because of using the imaging, identifying the thrombus and covering with the additional stent. The final result is very good, definitely. EPD is definitely useful, but fortunately in this case, though the thrombus has formed at the distal edge, did not migrate downwards. Otherwise, it would have given more problem to the operator.
Yeah, vein grafts behave very erratically, and there can be thrombus, there can be atherothrombotic material, and it's very difficult. I mean, fine, you can say that on IVUS, it looked like a thrombus, but it could be many more things, a mixture of that. You can never be sure. So probably the only action that you can do is try to cover it again with a stent. And I think if there is a large one, probably a covered stent would be better, because if the thrombus gets disintegrated and broken up, then you land in trouble because it always goes in the distal vessel. So it's always a difficult decision, and you have to decide and try to do whatever is best for the patient.
Previously,
Shall
we
we
had
move on to the? Yeah, please.
no. Previously,
Please,
we had
Dr.
this.
Javed.
Previously, we had this M-Guard stent, which would have been a good choice in these situations.
In fact, in olden times, we used to have symbiote stents, which was another sandwich stent, and we used to use it, but they come and go. Nothing remains. M-Guard also sort of just disappeared one fine day, so we can't do anything about it.